Right now, if you go in for a major surgery, you kind of expect the surgeon to just trust their eyes,
Yeah.
right? Like they look at the x-ray, they spot the torn ligament or the blocked artery, and they just go in to physically fix the damage they can clearly see.
Right, yeah. The visual evidence guides the scalpel. That's pretty standard.
Exactly. The eyes guide the hands. But today, we are looking at this highly complex surgical decision where a surgeon's eyes can actually, well, lie to them.
Totally. It's a wild concept when you really step back and look at it.
Yeah, we are talking about a scenario where the medical team has to look past the physical anatomy they see in the operating room and rely entirely on this, like, inventable number.
Right. In this specific corner of medicine, an invisible pressure metric doesn't just inform the surgeon, it can completely overrule what they are seeing with their own eyes.
So, welcome to today's deep dive. We are taking a massive stack of, frankly, incredibly dense urological guidelines, clinical trials, and these big international continence reports to answer one highly specific, game-changing question.
And it is a fascinating question.
It really is. How does a single invisible urodynamic measurement, something called maximum urethral closure pressure, or MUCP, dictate the exact surgical treatment a woman should get for stress urinary incontinence?
Yeah, MUCP. It's the acronym of the hour.
Right. And before we even get into the weeds of the science here, we really need to acknowledge the human element. Because if you, or someone you love, is navigating stress urinary incontinence, which, by the way, is incredibly common, this isn't just some clinical abstraction.
No, not at all. The psychological toll is massive.
Yeah, we are talking about the anxiety of, sneezing in public, the fear of laughing too hard, just the way this condition shrinks a person's world.
Absolutely. And choosing the wrong surgical tool just because a care team ignored this urodynamic number, well, it often leads to repeat surgeries.
Which nobody wants.
Exactly. It leads to severely worsened symptoms and these complications that can literally take years to unravel.
Knowing this one specific number could be the difference between a permanent, life-changing cure and a painful, agonizing surgical failure that just leaves you worse off than when you started.
It really is that high stakes.
Okay, so let's unpack this. For the listener who might just be catching up, stress urinary incontinence, or SUI, is the involuntary leakage of urine during exertion. Coughing, lifting a heavy box, going for a run.
Right. It's a mechanical failure, essentially.
And to help us decode the complex biomechanics of the human body and figure out how we actually fix this, I've got our resident expert here. So I am looking at all these guidelines, and they just keep pointing back to this invisible force. What exactly is MUCP, and how do you even measure an invisible pressure inside the human body?
Right. Yeah, it sounds like magic. But to get to MUCP, we first have to look at the diagnostic test they use to find it. It's called urethral pressure profilometry.
That is a mouthful.
It is, yeah. You will usually see it abbreviated as UPP in the medical files. So picture a very thin, highly specialized catheter. A clinician slowly pulls this catheter through the urethra, which is the tube that carries urine out of the bladder. And as that catheter moves, it is continuously measuring the fluid pressure that's required to pry that closed tube open.
Okay, so it is essentially measuring the internal grip strength of the urethra.
That is actually a great way to think about it. And the maximum urethral closure pressure, the MUCP, is the peak of that grip.
The peak grip strength, okay.
Right. It is the absolute maximum difference between the pressure inside the urethra and the pressure inside the bladder. So as long as the pressure in the urethra is higher than the pressure in the bladder, the door is held shut and you stay dry.
But the sources measure this in something called centimeters of water, which, that sounds a bit like a weather report to me. What does that actually mean in human terms?
I know, it's a very niche unit of measurement, but just think of a literal, clear plastic tube standing straight up in the air.
Okay, I'm picturing it.
If a muscle has a closure pressure of 50 centimeters of water, it means that muscle can squeeze tightly enough to hold back a column of water that is 50 centimeters tall before the water forces its way through.
Oh, wow.
Yeah, it's a direct measurement of mechanical resistance.
Okay, I was trying to visualize this while reading through the urodynamic studies, and I want to try an analogy on you.
Go for it.
If you think of your bladder as like the faucet on the side of your house, and the urethra is the garden hose connected to it, MUCP is basically how hard your thumb is pressing down on the end of the hose to stop the water from flowing out.
I like that. Let's build on that, actually, because it's a solid visual.
Okay.
So if that faucet is suddenly turned on full blast, which, in the human body, that simulates the sudden, violent abdominal pressure of a cough or a sneeze, Your thumb has to press down with a greater force than the water pressure rushing up behind it.
Right, otherwise you get sprayed.
Exactly. If the water pressure spikes higher than your thumb's grip, you get a leak.
So what is a normal thumb pressure for a human being? Because I was reading the baseline formulas in our sources, and frankly, I felt personally attacked by the math here.
Uh-oh, which formula did you see?
Well, one standard formula for calculating a normal MUCP is 92 minus your age, meaning this pressure naturally drops every single time you celebrate a birthday.
Yeah, it is a pretty sobering formula. There's another one heavily cited in the literature too, which is 110 minus your age, give or take 20%.
Still depressing.
Yeah, but the underlying biological reality is the same across the board. The overall grip strength of the urethra naturally declines as we age.
Why is that exactly?
Well, estrogen levels drop, which thins out the mucosal lining that helps create a watertight seal. Plus, tissues just lose their elasticity over time, and the collagen matrix that gives the sphincter its bulk begins to degrade.
But wait, if the formula literally subtracts your age and collagen loss is just inevitable for everyone, does that mean every single older person is just mathematically destined to develop stress urinary incontinence?
Yeah.
Is it just a ticking clock?
It is a common assumption, honestly, but the biomechanics are more forgiving than that. Continence isn't a sliding scale of constant worsening leakage. It operates on a threshold concept.
A threshold, meaning you're totally fine until you cross a specific invisible line.
Yes, exactly. And that is where the math gets interesting. Your pressure can drop significantly over the decades, but as long as your thumb is still pressing just hard enough to counteract the spikes in bladder pressure, you remain perfectly continent.
Oh, I see. So it just has to be good enough.
Right. The trouble only begins when that closure pressure dips below a critical threshold. In the clinical guidelines, the danger area is often defined as the gray zone of 20 to 30 centimeters of water.
20 to 30, yeah.
Yeah. And once your MUCP drops below 20, you have officially crossed the line into severe dysfunction.
So if we are naturally losing this pressure over time, what physically happens inside the pelvis when it drops below that critical threshold of 20? Because according to the clinical guidelines in our stack, hitting that number entirely changes the surgical rulebook.
It really does. When the pressure bottoms out like that, it is known as intrinsic sphincter deficiency, or ISD.
ISD, got it.
This means the urethral sphincter itself is fundamentally compromised. And it's important to note that while aging is a factor, severe ISD is often the result of trauma, previous failed pelvic surgeries, radiation therapy, or neurological disorders.
So it's not just getting older.
No. In these cases, the muscle fibers and the mucosal seal have simply failed to do their job entirely.
The visual descriptions of ISD in the source material are incredibly striking. I was reading that when surgeons look at a healthy urethra with a camera during a cystoscopy, it looks closed and plush.
Right, lots of healthy tissue.
But when they look at an ISD urethra, they describe it as a stovepipe or a lead pipe. Like it is just sitting open at rest. It's funneling. There's zero natural squeeze to it.
Yeah, stovepipe is a great descriptor. And what's fascinating here is how much that specific visual disrupts the historical understanding of incontinence.
Right.
Well, for a long time, the medical community viewed almost all stress urinary incontinence as purely a hypermobility issue.
Hypermobility meaning the internal organs are just like sagging out of their proper place.
Yeah, that was the prevailing theory. The idea was that childbirth or heavy lifting caused the pelvic floor hammock to stretch out, so the bladder, neck, and the urethra would sag downward.
Okay, makes sense.
And when the patient coughed, instead of being compressed against a firm backstop, the urethra would just get pushed further down and out of the way. So the traditional common sense fix was simply to lift the sagging anatomy back up into its proper position.
I look at it like trying to fix a bridge. Like if the bridge is sagging, you just jack it up and put some steel support beams under it.
Exactly.
But if you have a stovepipe urethra, if your MUCP is in the single digits, just lifting it up isn't going to do anything, right? You're dealing with crumbling concrete at that point.
Yeah, that's spot on.
You can prop up the concrete all you want to make it level. But if the material itself has no structural integrity, it is still going to crumble the moment a car drives over it.
That hits on the exact paradigm shift the urological field had to undergo. If the tube is a rigid, open stovepipe, restoring it to a normal anatomical angle doesn't magically force the tube closed.
The water just pours right through.
Exactly. The water's still going to pour right through the lead pipe no matter what angle it sits at. This is why knowing the MUCP is absolutely vital. It tells the surgeon whether they are dealing with a sagging bridge or crumbling concrete.
Okay, so how does a surgeon actually use this invisible number to pick a tool off the tray? Let's walk through the surgical fork in the road.
Sure.
Say a patient comes in, they get the urodynamic test, and they have a normal MUCP. So their thumb is pressing hard enough, but the hose is just sagging out of place. What is the gold standard fix for that?
For standard hypermobility with a preserved MUCP, surgeons typically rely on mid-urethral slings, specifically a type called a transobturator sling.
Transobturator sling, okay.
Yeah, or they might also use what is called a single incision sling. These are essentially minimally invasive mesh tapes placed gently under the urethra. They just act as a backstop.
Okay, so just a little support hammock.
Right. So when the patient coughs, the urethra gets pushed downward against this tape, which gently kinks it shut.
Like stepping on the garden hose.
Exactly like that. And, it's worth noting for the listener, if a patient wants to avoid synthetic mush entirely, which is a very valid concern for a lot of people, the Birch-Klopot suspension is a highly effective alternative.
Oh, right. I read about the Birch procedure.
Yeah, it uses sutures to lift the vaginal wall and support the bladder neck without using any mesh. All of these options work wonderfully, provided the MUCP is normal.
But here comes the pivot. What happens when the surgeon looks at the urodynamic report? And despite what they see on the imaging, they realize the MUCP is sitting at, say, 15. The concrete is crumbling.
Yeah, that changes everything. If the MUCP is below 20, using that standard transobturator sling is a recipe for surgical failure.
Really, just complete failure.
Pretty much. The literature in our stack is incredibly clear on this. One major study tracked patient outcomes and showed that women in the lowest MUCP quartile had a twofold increased risk of objective failure 1 year after getting a standard sling.
Twofold? Wow.
Yeah, because the tape acts as a backstop, but a rigid stovepipe doesn't have the internal mechanism to squeeze shut against it. It just stays open.
So if the gentle hammock fails, what is the solution? How do you surgically fix a stovepipe?
Well, you have to completely change your surgical geometry. Instead of the transobturator sling, which sits flat horizontally, surgeons must pivot to a retropubic sling.
Retropubic, okay.
Or, alternatively, they can use an autologous fascial sling, where they actually harvest a piece of the patient's own tissue to create the support.
I need to stop you there because to a layperson, a sling is a sling. I mean, they both go under the urethra, right?
Right.
Why does a retropubic sling work when the transobturator fails?
It all comes down to the physics of vector forces.
Vector forces.
Yeah. A transobturator sling goes out horizontally through the groin. It is flat. But a retropubic sling goes straight up, passing behind the pubic bone, creating a very tight, narrow U shape.
Okay, I'm picturing a U shape now.
That upward trajectory provides active, compressive vector forces. It literally hugs and mechanically squeezes the stovepipe shut from the outside.
Oh, wow. So it's actively crushing it a bit.
Yes, it provides the heavy compression that the damaged biological sphincter no longer can provide itself.
That makes perfect sense physically. But it raises a massive question for me.
What's that?
Well, if the tight U shape of the retropubic sling gives a better squeeze, and it cures the absolute worst-case scenarios like ISD, why not just give that specific sling to everyone who walks through the door with incontinence?
That's a logical jump, for sure.
Right. Like, if it's the strongest option, why even bother with the gentler hammocks at all? Just give everyone the heavy-duty fix to be safe.
It is a very logical question to ask, but it brings us to the core of surgical risk versus reward. You really have to match the weapon to the enemy.
Okay, how so?
The sources detail that the retropubic approach involves passing large surgical instruments blindly up behind the pubic bone. And because of that upward trajectory, it carries significantly higher risks of puncturing the bladder during the surgery itself.
Yikes, that sounds incredibly dangerous.
It requires immense skill. And even if the surgery goes perfectly because it squeezes the urethra so aggressively, it carries a much higher risk of post-operative voiding dysfunction.
Meaning they can't pee.
Exactly. This means the patient goes to the bathroom, tries to pee, and they physically can't because the sling is choking the urethra. It can also trigger de novo urgency, where the bladder spasms violently against the new obstruction.
Wow. So by using the heavy-duty fix on a mild problem, you could cure their stress incontinence, but accidentally give them severe urinary retention or an overactive bladder. You just trade one nightmare for another.
Which is exactly why you never want to over-tighten a healthy urethra. If the enemy is just hypermobility, you use the gentle hammock. If the enemy is severe ISD, you bring in the heavy compression.
But what happens when the MUCP is so incredibly low, the concrete is so pulverized, that even a compressive retropubic sling fails? Because I saw something in the case reports about a mechanical cuff, but how does a piece of silicone actually replace a biological muscle?
Right. So when the intrinsic sphincter is essentially non-functional, or a patient has already had multiple failed slings, the gold standard recommendation turns to the realm of bionics.
Bionics, like actual robotics.
Sort of, yeah. Specifically, the artificial urinary sphincter, or AUS. It is an incredible piece of engineering.
How does it work?
It involves a fluid-filled cuff that wraps entirely around the urethra, a pressure-regulating balloon implanted deep in the abdomen, and a small control pump placed in the labia.
So the cuff just stays inflated all the time to hold the urine in?
Yes, it provides continuous mechanical compression, and when the patient needs to void, they manually squeeze the small pump.
Okay.
That temporarily pulls the fluid out of the cuff, opening the urethra and allowing the bladder to empty before the cup automatically refills and closes again a few minutes later.
It is literally replacing the biological thumb on the hose with a mechanical one.
Exactly.
But I would imagine the sizing of that cuff is wildly difficult. If you put a cuff on that is too loose, the patient still leaks. But if you put a cuff on that is too tight, wouldn't it choke off the blood supply to the tissue?
That is the greatest risk of the device, absolutely. If it is too tight, it leads to tissue ischemia, which is tissue death, and the mechanical device will slowly erode right through the urethral wall.
Which sounds horrifying.
Right.
So how does the surgeon know exactly how tight to make it when they're actually in the operating room?
This is where MUCP makes a triumphant return, but this time, live in the operating room.
Oh, wait, really?
Yeah, there's a fascinating case report in our sources detailing the use of urethral pressure profilometry intraoperatively. While the patient is open on the table, they use a specialized air-charged catheter, specifically a TDOC catheter, connected to ambulatory urodynamic equipment.
Wait, they're measuring the pressure of the artificial cuff in real time while the patient is cut open?
Yes. Once they place the artificial cuff around the urethra and activate it, they pull the catheter through to get a live MUCP reading of the new bionic system.
That is mind-blowing.
They are aiming for a very specific sweet spot in the data. The literature suggests aiming for a post-op MUCP above 65 or 70 centimeters water.
That is incredible. They are basically tuning the patient's urethra like a mechanic tuning an engine on a dyno.
It really takes the guesswork completely out of the equation. If the live reading is only 50, the surgeon knows instantly the cuff is too big and they can swap it out for a smaller one before they close the incision.
Right.
But if the reading shoots up to 120, they know it's dangerously tight and will cause erosion, so they size up.
Right. I have a major bone to pick with the source material here, though.
Uh-oh, let's hear it.
With all this precision, I mean, with MUCP literally dictating whether you get a gentle hammock, a tight U-shaped sling, or a bionic cuff tuned to the exact millimeter of pressure, you would think this invisible metric is universally worshipped in the urology world, right?
You would think so.
But when I read the official American Urological Association guidelines, they specifically call the clinical utility of urethral function assessment controversial. They explicitly note that MUCP doesn't perfectly discriminate between continent and incontinent women.
And they are absolutely right to point that out, which is why it is deeply polarizing among experts.
How can it be controversial if it's so precise?
Well, an older woman might have a very low MUCP of 18, well into the ISD danger zone, right? But because she has a sedentary lifestyle and great pelvic support, she never leaks a drop.
Oh, interesting.
Meanwhile, a younger woman might have a robust MUCP of 50, but because of severe hypermobility, she leaks every time she jogs.
But if the official governing body says this metric is controversial and the numbers overlap so much between people who leak and people who don't, why should anyone listening base a life-altering surgery on a controversial number? Aren't we giving them conflicting advice?
It is a brilliant question, and to answer it, we have to look at why medicine labels things controversial in the first place. It is usually because the medical establishment loves binary buckets. You either have condition A or condition B. But advanced studies, like the recent shear wave elastography research in our sources, show us that continence isn't a binary. It is a continuum.
A continuum meaning it's never just one failure point.
Exactly. Reduced urethral closure pressure accounts for about 50% of the physics of stress incontinence. Urethral support, the hypermobility factor, adds another 11% to the predictive accuracy.
Right.
Surgical failure almost always happens when a surgeon treats the hypermobility but completely ignores an underlying mild sphincter deficiency.
Ah, so it's a combination of the hose sagging and the thumb getting weak at the exact same time.
Right. MUCP isn't a standalone magic 8 ball that gives you a yes or no answer in a vacuum, but when you combine it with the patient's physical history, have they had prior surgeries? Do they leak without even coughing, just standing up? When you combine all that, MUCP becomes an essential, irreplaceable compass. It is the only warning sign a surgeon has that a standard, low-risk approach is mathematically destined to fail.
Man, we have gone on quite the journey today, from fluid dynamics to biomechanics.
We really have.
We started by learning that MUCP measures the physical internal grip strength of the urethra. A normal grip means the standard, less invasive sling options, like a transobturator tape, are firmly on the table.
Yep, the hammocks work great there.
But a weak grip intrinsic sphincter deficiency demands compressive techniques, like a retropubic sling, an autologous fascia sling, or even the intraoperative tuning of an artificial urinary sphincter.
And the overarching lesson for anyone navigating this is that anatomy is completely individualized. The exact same symptom leaking when you sneeze can be caused by two entirely different mechanical failures requiring two entirely different surgical tools.
And this brings us right back to you, the listener. If you or a loved one are facing these daunting medical decisions, understanding what your MUCP is profoundly empowers you.
It really does. It puts the power back in the patient's hands.
It allows you to sit across from your surgeon in the consultation room and ask why they are recommending a specific sling. It gives you the vocabulary to ensure your treatment is tailored to your unique anatomical data, not just a one-size-fits-all conveyor belt approach. Knowledge is your best defense against surgical failure.
Absolutely. Asking about your urodynamic results forces the surgical team to explain their rationale. It ensures they aren't just looking at the anatomy, but actually measuring the physics of the problem.
Well said. Before we wrap up this deep dive, I want to leave you with a final thought to mull over, something that pushes past the boundaries of the clinical guidelines we've discussed today.
Let's hear it.
We've established that a dropping MUCP is ultimately a measurement of failing muscle strength, degrading tissue elasticity, and irreversible collagen loss. And right now, our only answers are entirely mechanical mesh slings, harvested tissue slings, or silicone bionics.
Right, just propping it up.
We are essentially treating a biological failure with a mechanical crutch. But could the future of stress urinary incontinence treatment bypass these mechanical slings entirely?
Oh, that's an interesting direction.
Imagine a world, maybe 10 or 20 years from now, where a surgeon doesn't implant mesh at all. Instead, they use localized regenerative medicine. Imagine targeted stem cell therapies or advanced biotissue engineering injected directly into the sphincter.
Just regenerating the tissue itself?
Exactly. Forcing the body to reprogram its own collagen matrix, reversing the structural decline of the urethra, and rebuilding its own MUCP naturally from the inside out.
That would be revolutionary.
Suddenly, we aren't just managing the leak with a piece of tape. We are curing the root cause by giving the body its grip strength back. It makes you wonder how long the scalpel will remain the ultimate tool for this condition. Thank you for joining us on this deep dive. Keep questioning the standard answers and stay insanely curious.